Yeah, so one of the anatomic challenges that's common is a periambulary diverticulum. The biggest piece with these is understanding what you're looking for, and usually the opening is on the medial sides of the diverticulum or at the base. So one of the techniques to best visualize that is sometimes advancing your scope into what we call long position, so you're getting closer to the actual opening.
Hi, everybody. Welcome to another episode of ENDOcast. I'm your host, Leslie Bishop, and this is episode 26 with our physician guest, Dr. Sri Komanduri from the Northwestern Feinberg School of Medicine. ENDOcast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you.
All right, Dr. Komanduri, welcome to ENDOcast.
Thank you.
I'm very excited to talk to you about ERCP today, but maybe before that, I'm sure our audience would love to know just a little bit about you. Can you tell us your journey into medicine, into interventional GI?
Yeah, so I started my training in medical school at the University of Miami in Florida, and then did my training in Chicago. And this was completed about 21 years ago at Rush University Medical Center, and then took on a job there, and subsequently I've been working at Northwestern in interventional endoscopy for the last 15, 16 years.
So you left Florida and you've been in Chicago this entire time.
Yeah, I grew up in Chicago and transplanted to Florida for medical school and then back to Chicago.
Okay, you like the cold. You didn't
Yes.
want to be in the heat.
Exactly.
Okay.
Yeah.
All right. And then what's the focus of your practice now?
So I currently serve also as our associate chief for our division of GI. So I spend about 40% of my time integrating our healthcare system in GI across 13 hospitals.
Oh, wow.
But otherwise, my practice is an interventional GI inclusive of pancreatico-biliary endoscopy, tissue resection, with a research interest in esophageal cancer and Barrett's esophagus.
Okay. All right. Well, today we're going to focus just on the ERCP part. So
Correct.
I want to start really on difficult cannulation and then maybe talk about a few kind of device type questions. But before that,
I know you've been using our devices
for a long time.
So I'm just curious why you started using Boston Scientific in the first place.
Yeah, so the journey has been long. It's actually been right around 25 years since my first communication with the company, spanning a lot of technology over the years, pretty much everything that is in your portfolio. But really it's around a couple of things. One is relationships, and I think as we try to move so many new procedures and technologies forward to reimbursement in a very different environment, and so that relationship is critical. And the second part is the BSc mentality around what I would say is this transformative innovation, which includes really breaking barriers of things that were once ridiculed and now considered self-evident, even things like placing metal biliary stents. And, these are things that people said you should never do, and now we do them without even thinking. So this is very sort of representative of the way Boston has really innovated themselves over the years. And so I think that type of quality in endoscopy and technology is why I've been with working with the company for so long. I think the last piece is just sort of and it speaks towards the Autotome Pro, is iterative innovation, which really is never getting sort of stuck in the setting of being comfortable with what you've produced and always looking at old technology that may have been successful but needs iteration and new innovation. And the Sphincterotome is a great example of re-looking at something that was very successful but needed a refresh.
So where do you see the gaps in pancreatico-biliary? Where do you see innovation gaps?
Pancreatico-biliary endoscopy centers, I think now around access, diagnostics, therapeutics, there's a lot of little areas for growth. Much of it is around endoscopic ultrasound and biliary access. I think that is one of the big waves of the future, and there's a lot of technology within Boston to do so. A good portion of this, though, still goes back to innovation to the community gastroenterologists who are taking on more interventional work, which then brings us back to very simplistic biliary access. So again, the idea of iterating the existing tools like sphincterotomes are critical for just that day-to-day procedural work for common bile duct stones or biliary access that can be translated across a healthcare system.
All right, so kind of moving on to technique and challenging difficult cannulation. How does your approach change depending on the papilla classification?
Yeah, so I think part of ERCP is being prepared mentally with you, the staff, and also your tools for a difficult cannulation that happens to all of us. Having adequate time to take on these cases and making sure your staff is adequately trained. Part of the physician training and even our fellows training is immediately assessing the anatomy to understand where the case might go and how challenging it might be. And so whether it's a sort of flat or retracted papilla that seems very straightforward to the ones we see that are very accordion and boggy, these types of papillas will take longer. They might need different tools or sphincterotomes that can bow and go at a higher trajectory. A lot can be gained by just that visualization of the anatomy, such that you're mentally already planning what's going to happen 5 steps ahead.
What happens when you keep having failed cannulation attempts? What's your step then?
Yeah, so I think as we train for ERCP, there's lots of approaches to failed cannulation. I think the go-to approach for me and many people is also based on risk, which is the double guide wire cannulation. So most of the time we end up in the pancreatic duct and unable to get biliary access. And this works 95% of the time in those challenges. But you do escalate then too into higher risky categories like a pre-cut or needle knife sphincterotomy or even EUS guided access. And I think you have to just stop and ask yourself, A, is this within my skill set? And if not, it's not horrible to stop and refer the patient. Or B, is the indication worth the risk? And are you doing something marginal, or does this patient have cancer and they're jaundiced and we should take that elevated risk? If so, there are multiple options there to achieve success.
So for somebody who's maybe new, maybe they're a fellow, how would you explain to them the double wire technique?
So the issue generally is for a fellow new graduate is it's pretty easy to get into the pancreatic duct, and we preferentially do. So once you're in the pancreatic duct, there used to be different ways of how many times do I have to get in there? Do I have to have injection before I go to double? Now it's pretty evident if you're, after a couple times, you're just going to keep going that direction. Then we just leave the guide wire in place, exchange off the sphincterotome, and then we redirect the sphincterotome to try to actually fluoroscopically almost get a 45 to 75 degree angle on the imaging, which gets you in that upward trajectory, so you might have to bow the sphincterotome towards the bile duct, and then we advance the second wire. And usually that works pretty quickly into the bile duct.
All right, and then how are you managing access with a patient that has maybe a diverticulum, or maybe they have a distal obstruction that's making it challenging?
Yeah, so one of the anatomic challenges that's common is a periambulary diverticulum. The biggest piece with these is understanding what you're looking for, and usually the opening is on the medial sides of the diverticulum or at the base. So one of the techniques to best visualize that is sometimes advancing your scope into what we call long positions, so you're getting closer to the actual opening, more so to visualize and understand where you need to go. Secondly, it's not always a straight trajectory. Sometimes the track of the bile duct is going in an opposite than typical direction, maybe going downwards or to the left. So this is where a rotatable sphincterotome, for example, that like the Autotome, is extremely valuable. And that may not be much more than a couple of clicks on the handle to get it to go a little more in one direction, but that can be priceless in making sure you get cannulation of the bile duct.
So when you're in a case, how often are you having to turn the tome and change the direction?
So the advent of that rotatable property of the sphincterotome is mostly beneficial, but extremely beneficial in duct access, specifically like hilar obstruction or multi-duct obstruction. But in altered anatomies like the periambulary diverticulum, or sometimes in like a Billroth 2 where the papilla is in a different position, quite often it's a great asset to have when you're struggling.
With difficult cannulation, what would you say is like your number one technique? If you're just going to give your best tip in a difficult cannulation, what is it?
Yeah, it should be double guide wire technique. I think that's, and assuming you're actually achieving pancreatic access, it's the technique which I feel is the most successful.
All right, and then how are you mitigating issues that arise if the tome is not oriented correctly?
Yeah, this is a problem, and we continue to hope that new iterative technologies like the Autotome Pro, for example, might solve this. The issue is that, I think we sometimes put too much on the device, and we need to think a little bit about, is it the shape of the stomach? Is it the, any anatomical deviation also makes the device change how it's passed through the channel. And so we often we'll immediately blame a device, right? But it's not always in the device's best interest to come out in that angle. So one of the ways is, if it's truly off by a few degrees, we can do things like rotate, like we're talking about, rotate the sphincterotome or go into a long position. But I think that there is opportunity for innovation there that is occurring. So hopefully we'll at least get a little more consistent, with some of the new sphincterotomes.
And then thinking about the insulated tome, how does that help you with gaining access?
Yeah, so the adding insulation, it gives you a little bit, especially on the Autotome Pro with sort of the colored insulation that you can see as a set point. I think most importantly, even besides access, it gives us a mechanism. So you know exactly where you need to cut when you're doing a sphincterotomy, but it provides you, I think, like a focal point to where you're kind of always going to start from in terms of whether you're bowing or not bowing. Sometimes without that, you're not sure how much is in the duct, is not in the duct in terms of the actual sphincterotome wire itself.
All right, and we've got different lengths and different bowing. Like, how do you decide how much you want the tome bowed?
Yeah, I mean, I think it's, again, based on the assessment of the papilla, and, you'll kind of understand if you need to go straight in or you need to go upward trajectory. And so I think some of it is trial and error, but some of it is just the anticipation of the angle of that bile duct. And that, again, is just a experience-driven issue.
For somebody listening who wants to improve their skills, maybe they're not at an academic center and they're not getting huge numbers, what tips would you give to them?
If you're doing a lot of ERCP, especially expand into the communities now, doing higher skill requiring procedures, I think having adequate training and volume. Once your fellowship is an easy time, but at post-fellowship there are courses through societies, there are industry-driven education, and a lot of online material like Boston Scientific has done with Educare and other avenues that just getting in front, and sometimes just picking up a phone and talking to a colleague or saying, hey, I don't have the skill set and I need to refer this patient. But I think there are opportunities for training beyond fellowship.
And I'm curious to know, when you're looking forward, what really excites you in the future, especially with innovation related to ERCP?
Yeah, I think, more than devices itself, I think what needs to happen and what's really exciting, and this comes in my role a little bit, is we have to spread higher levels of pancreatic biliary endoscopy across healthcare systems, across community advanced endoscopists. And that's not always a popular opinion, but it is the reality of we got to reach patients where they live. And that's happening in a lot of our places. So with that comes better training. It will come with newer innovation, new devices.
Okay. This has been awesome, but I want to turn it back to you. Is there anything I haven't asked you about that you want to share in terms of difficult cannulation, ERCP, that might be helpful to our audience?
No, I think, again, the most important thing in performing any ERCP are a few caveats. One is ensuring our staff is adequately trained and you have the right team and they're prepared. Number two is making sure that you're taking on difficult cases, that you have the bandwidth of time to give you the patience, avoid frustration of difficult cannulations. Number three, your plan. You have your algorithm in your head of what I can do, what I can't do, being humble, realizing limitations, and then asking for help when it's time.
So with the training, how are you making sure your staff is appropriately changed? What do y'all have where you are to make sure of that?
Yeah, it's a great question. And it is a need. It's something we do need to work better with. How do we develop some standardization to develop teams of advanced endoscopists? I think there are settings where it's not practical, and those are settings where we do very basic ERCP, level 1 kind of ERCP, where you just don't have enough nurses to have specialized teams or techs. But when you start escalating above that and you're doing anything of a more complex nature, I think you have to have those teams. So we don't have formalized training programs. I think we do a lot of internal training, and the experienced nurses help. But as we spread again across communities and systems, we need to develop a program similar to everything we do for physicians for nurses and techs.
Yeah, that'd be amazing. Absolutely. Yeah. All right. Well, Dr. Komanduri, this has been amazing. I appreciate you coming on today.
Of course. Thank you.
Thanks for listening to this episode of EndoCast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, Educare. That's edukare.bostonscientific.com and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. EndoCast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary.
Thank you.